Episode 36, Lightheaded After Training. Welcome to Sports Medicine Case Studies, where I review published case studies in sports medicine, discuss key takeaways, and provide some practice questions at the end. Case today, a 30-year-old man who is a competitive endurance cyclist gets referred to a university medical center after being told he has a right bundle branch block on an EKG. Over the prior year, since increasing his training to up to 5 sessions per week of cycling and distance running, he has experienced roughly 10 episodes of lightheadedness and 1 frank syncopal episode. These episodes always occurred in the initial minutes after finishing his aerobic endurance training, while he was seated. They were accompanied by disagreeable palpitations. When he presented, his physical examination was described as normal. There were no thoracic or cardiac abnormalities detected. There was no family history of premature cardiac death. Initial laboratory studies were described by the authors as unremarkable, with no signs of inflammation or other abnormality. Echocardiography was normal. There were no structural or functional abnormalities identified in either ventricle. An active orthostasis test did not produce any additional symptoms. So, my differential diagnosis, I'm still including structural cardiac abnormalities, even though the echocardiogram was normal, and primarily I'm thinking arrhythmia. So I'd like to recognize the authors of this case. This case was published in the British Journal of Sports Medicine by Esperer, Hose, and Hettenroth. I'm Scott Hull, a primary care sports medicine physician, and I am studying for my sports medicine certification exam in 2026, and I hope you will join me on the journey. This podcast is for educational purposes only. Okay, the resting EKG showed a sinus rhythm of 75 beats per minute. The intervals, including P wave, PR interval, QRS, QT, and QTC, were all within normal ranges. But the precordial leads revealed a spontaneous type 1 Brugada EKG pattern with markedly increased J-wave amplitudes. The measurements reported by the authors included an elevation of 3.5 millimeters in V1, 5.5 millimeters in V2, and 4 millimeters in V3. This is the only EKG pattern that is diagnostic of Brugada syndrome, where a coved ST segment elevation of at least 2 millimeters is observed with T-wave inversion in the precordial leads. Critically, in this case, the EKG changes were occurring spontaneously, which is associated with a unfavorable diagnosis compared to patterns that are only unmasked by a drug challenge. An earlier EKG obtained during a non-exercise period showed only a slight saddleback ST segment elevation of 1.6 millimeters in V1, which does not meet diagnostic criteria for Brugada syndrome. This comparison of the pre-exercise EKG versus the current EKG demonstrate one challenge with Brugada syndrome is that the EKG pattern can be variable and fluctuate over time. This patient underwent a graded exercise test and completed a workload of 280 watts without any symptoms. During the test, the J-wave amplitudes in leads V1 through V3 progressively decreased with an increasing workload. At peak exercise, the J-wave amplitude in V1 had dropped to 0. But during recovery, the J-wave amplitudes rebounded dramatically. Within 3 minutes after exercise, they exceeded pre-test levels by 80% in V1, 44% in V2, and 100% in V3. This pattern, with attenuation during exercise and augmentation during recovery of EKG changes, has since been confirmed in larger studies. One study done by Makimoto and colleagues in the Journal of the American College of Cardiology found that among 93 Brugada syndrome patients, 37% showed significant augmentation of ST segment elevation during early recovery. And this augmentation predicted future cardiac events. The ST segment amplitude peaked at approximately 3 minutes of recovery in our case, which is exactly what one would expect.